I know people here, but not everyone. My name is David Jones. I'm on faculty here in the Department of Global Health and Social Medicine, sitting for Scott Podolsky, who generally runs this seminar series. It's my pleasure to introduce our speaker today, Dr. Mark Shrime, who is in the Global Surgery Group. And now, as some of you know, this department historically had been focused almost entirely on infectious disease and mental health from its 1980s through to the early 2000s. By silver, in the lecture Paul Farmer was giving to the first-year medical students in 2008 or 2009, someone like, now that he had solved the problem of infectious disease, which is a bit of a premature claim, but there's great success in Haiti and other areas, what we see as the biggest healthcare problem facing populations in resource-poor settings. And to everyone's surprise, his answer was surgery. And I don't think it'd be a surprise to surgeons, but a surprise to the people in the room. And he said the thing that really caused him the most pain and angst, and where he saw the most opportunity for improvement in healthcare conditions, was the area of surgery. He said nothing that bugged him more than women dying in childbirth, or the child dying in childbirth, where each of them could have been saved with access to relatively simple to develop surgical technology. And he said this is a problem that we have to take on. And with the Haiti earthquake in 2010, where an immense amount of the burden of disease post-earthquake was orthopedic and surgical, that sort of down on his interest trying to figure out how to do this. And so he had the good fortune to come across John Mira as a collaborator, John in to create a program in surgery and global change, and has been a really successful endeavor. Many of the people who are involved in that are here in this room. John has created around him a very group of very successful research and care delivery people who help to put surgery on the agenda for global health through the global commissions and other kinds of work. So that's the broad context of that, and that's why surgery is now one of the most interesting areas of work this department is going into, despite that it is from mental health and infectious disease. Did his undergraduate work at Princeton Medical School in Texas, trained in otolaryngology, ear, nose, and throat surgery, and then did something I think is still relatively unusual for practicing surgeons, is completed his training, then came back to school, first for an MPH here at the Harvard School of Public Health, and then continued on for a PhD in health policy in the decision science track, and put his dual training to good use, taking on these huge questions of how do you deliver surgical services as effectively and efficiently as possible to help overcome the tremendous gap between the demand and availability of surgical services on a global scale. We'll be talking about some of his research on that project. Thank you.
Thank you. First of all, can you guys hear me in the back? You can. There are seats here in the front. I promise I showered, if you want to come closer. So thank you for that introduction. My name is Mark. I am the research director for John's program in global surgery and social change up on the floor, and an assistant professor of ENT and of global health and social medicine here at the medical school. By side, though, I recognize about 20 people that are all clustered right there from the global surgery program. One sense of who I'm talking to. So how many in here are faculty? Okay. In surgery, besides the guys that I know, folks that I know, and in some sort of global health field, about 30% of this whole row. Yes, that's right. Research in global health. Okay. Great. Good. I'm going to actually poll you on actually in a few slides. But I titled my talk "Sustainable Development in Global Surgery" because in the global surgery world, we love these words. We love the word sustainable, we love the word development, but I think if you asked us what sorts of policies would bring up sustainable development in global surgery, I'm not sure we could necessarily answer that question for you. And that's what I'll talk about today. Oh, that's not. I've nothing to two current funding sources, but besides on this slide, you won't see them mentioned ever again. I miss not to acknowledge my co-authors on the paper that I'm presenting to you today. Surface Gide, Josh Solomon, Jessica Cohen, and Milt Weinstein. So what I want to do today is I'm going to start by seeding this question in its context. The sorts of policies and platforms bring about sustainable development in global surgery, seated within the global surgery context. And I'm going to spend a fair bit of time in this ground because there are a lot of moving parts. We'll look at a number of different policies and platforms. We're going to look at them from 3 different angles. As I said, I'm going to ask you to vote on some of these policies and platforms in minutes. So we'll have some time. And the methods. Before I do, I'm going to take a bit of a whistle-stop tour around the prevalent policy analytic methods of global surgery, why they aren't necessarily sufficient for answering the question of sustainable development in global surgery. We'll move on to the results and some conclusions from the results. When I design my talks that will last an hour, I find them to be 35 minutes stem to stern, because I feel these research talks are better spent as a conversation. So I've built plenty of space here for you all to interrupt me at any point, raise your hand, ask questions, push at me, tell me I'm wrong, tell me I'm missing things, call me an idiot. All those things are perfectly fine. And it's a small enough group that if I don't see you raise your hand in the back, just call out to me. We've got plenty of time to talk about this, and then there's time at the end for questions. Deal? Okay. So what's this background? And I motivate this talk with 2 patient stories. The fellows have seen both of these patients before. The first patient of mine from Madagascar, her name is Patricia. She's had the tumor growing up the right side of her face for the last 30 years. The section is also from Madagascar. His name is Sambani. He's a farmer from the southern part of Madagascar, and he's had this tumor growing off the left side of his face for 30 years. Patricia and Sambani's stories are a litany of the barriers that patients in low-income countries face when trying to access surgery. In her 30 years, Patricia had been to see a number of surgeons, none of whom wanted to offer her a procedure that she could afford. 30 years. Sambani had been to 10 different hospitals. Only of them had surgeons in them. None of them could offer him a procedure that he could afford. Patricia and Sambani had their surgeries on the east coast of Madagascar with an NGO that I work with. This was a rice farmer from the southern part of Madagascar. So to make that trip from south to the east meant that he had to be carried on somebody's back for days, just to the nearest road. And then it was a 6-hour trip up the road to get to the hospital. Barriers of distance, of transportation, of a lack of providers, a lack of procedures offered by providers. But the bit that interests me the most, the part of Sambani's story that compels me the most, is this. The NGO that did their surgeries does surgery for free. The surgery, post-op care, the medications, the rehab, all no cost to patients. But to that 2.5-day trip from the south to the east of Madagascar, this farmer had to sell his rice paddy. Faced and shouldered a catastrophic financial event in search of his surgery. And Patricia and Sambani are not alone. Those of you who have hung around 641 long enough have seen these numbers. 2% of the world's disease burden requires decision-making at some point in its disease course. But 5 billion people around the world don't have access to safe, timely, and affordable surgery. Of surgery every year, 81 million of them, or 10% population of New York City, are pushed to poverty. Somebody was by the cost of surgery. 20% of people who get surgery every year are cured into destitution. Now, ask people who don't have access to surgery why they don't. They'll give you a number of answers. They'll talk about some demand-side barriers, like, I just can't afford it. They'll talk about some supply-side barriers. There aren't enough surgeons, or I'm concerned about the quality of the surgery that I would get. But by far and away, the most commonly cited barrier to access surgery in low-income countries is cost. Which, for me, cost is super fascinating because it's both sides of the equation. Barrier to accessing care, but it also has toxic downstream side effects. Impoverishment is a side effect of surgery for 80 people around the world every year. This seems like something that we should care about. These also don't distribute themselves equally across the population. They fall most heavily on the poor and people with serious disease, like Patricia and Sambani. So barriers to accessing surgery have an effect on 3 axes, 3 domains. They have an effect on a domain of health. If you have a tumor going up the left side of your face, your health is diminished. But from somebody's story, they have an impact on a domain, on an axis of financial risk, and the questions of equity. And are the same three axes as one of the world's sustainable development goals. The WHO said that for countries to expand to achieve universal health coverage, they have to expand in three ways. They cover more things in their systems, they have to improve the health of them. They cover more people, they have to improve the equity of the system, and they have to protect against financial risk. So any platform that we propose to improve access to surgery will, by definition, have an impact on all three of these axes. So we should probably study the impacts on each of these axes. I'll get to that in just a second, because what I'll do next is take you through some of the common policy platforms that are proposed to improve access to surgery. And I've split this part of the talk up somewhat arbitrarily into governmental policies and non-governmental platforms, but there is some overlap between these two buckets. Most common policy governments turn to when trying to improve access for their population to any health intervention, including surgery, is to say, surgery is really expensive. Let's make surgery less expensive. Let's remove user fees. Let's make surgery free at the point of care. A really common policy. This paper, Uganda, evaluates that particular policy in C-section. You can go to any global surgery meeting right now without hearing about our favorite golden child policy that's going to fix every surgery, which is tax shifting, training surgeons to provide a limited bundle of surgical services. And countries, much more rare, have tried other policies like vouchers for those non-medical costs of care, the cost of transportation, the things that impoverish somebody. But in a lot of sub-Saharan African countries, more surgery is provided by the NGO sector, the non-governmental sector, than is provided by the public sector. And that's often because NGOs tend to provide surgery for free. The sector operates in one of three basic ways. The majority of NGOs, 67% of surgical NGOs, use a short-term mission trip model. Fly in, do surgery, fly out again, maybe come back the next year. Most NGOs use this model. Others will take the opposite end of the spectrum and will commit to a region for forever. They'll build a permanent specialty mission hospital, like a physical clinic in Ethiopia or a center of excellence for cleft lip and palate surgery in India. And more rarely, some NGOs, the U.S. military, and governments have tried semi-permanent mobile surgical units. This is an NGO in Ecuador that uses trucks to get surgery out into the hinterland of Ecuador. Try this out now. Yes. India has at least a century of global health expertise. So I want you guys to get your sense, before we even talk about these, your sense of which of these 6 policies and platforms actually have the most impact. Impact, however you want to define impact. So you pull out phones, t.com. You don't have to give them any email address or anything else. Just put in the code 795764 and vote on which of these 6, remove user fees, taxing, valid medical costs, 2-week mission trips, mobile surgical units, and specialty hospitals. You want to define impact. Get to that.
And you can only pick one?
If you wanted to vote. Not surprisingly, given the room here is from the global surgery, task shifting has won this particular race. but for non-medical costs are next. Nobody likes a 2-week mission trip. The rest are about equal. So that's actually the question that I wanted to answer. I wanted to know which of these policies and platforms would have the biggest impact on surgical patients and surgery areas, with impact, to Alex's question, being defined as an improvement across all 3 of these axes of universal coverage: an axis of health, of financial protection, and of equity. Because I had a hypothesis that if we choose more realistically, if we were to choose policies based not just on their impact on health, their impact on other things that patients have to face when they enter the health system, we might end up choosing different policies than if it was just based on health. So how do I answer this question? It turns out it's not the easiest of questions to answer. It's relatively difficult to study. You can't do an RCT on this. You can't randomize one country to getting vouchers and then part of the country to getting mobile surgical units. You could, but that would be very expensive and time-consuming. In the global surgery space, there are, as far as I know, no published RCTs that analyze policy. There are a couple of RCTs that are being run out of here. So we're starting to build this sort of policy analytic RCT space, but it hasn't been built quite yet. The majority of papers that are published in global surgery over the last 15 years are observational. These tend to be small studies, and they tend to be hospital-based, which introduce a fair amount of selection bias. Studies like this one, I've dropped the authors of all these studies, so I don't want to pick on the authors, I just want to pick on the studies themselves. So this one, which looks at the cost per daily averted in a small hospital in Sierra Leone. So it's hospital-based, but also it looks just at one axis. It looks just at an axis of health. Cost per daily averted, simply an axis of health. We do have a growing body of intervention analyses, intervention outcome analyses in global surgery, but a lot of these are predicated on what's called a pre-post design. This is a good example of one such study. It looked at the effects of a policy to improve access to surgery, also in Sierra Leone. The policy that they looked at is a policy that we're all familiar with in this room. It's a policy of accompaniment, a policy of twinning high-income country surgeons with their Sierra Leonean counterparts to see if it will allow an improvement in access to surgery. And the metric they used to judge their access to surgery was improved was simply surgical volume. The fact that surgical volume isn't on any one of the 3 axes that we were talking about, let's just take their outcome at face value. And find that over the course of their twinning program, surgical volume in this hospital in Sierra Leone goes up. So they could, from that this program improves access to surgery. It has additional results, and a model that should be used in other resource-constrained settings. To me, these sound like really hefty conclusions from what is essentially aligned. Measure volume before their intervention, volume after their intervention. They find that it goes up, and say, look, our intervention works. They make 2 fundamental errors in doing this, though. The first is that they make an assumption without any evidence that had their training program not been there, this would have happened to surgical volume. But they know for a fact that this would not have happened to surgical volume, or what we like to call the counterfactual. And attribute the entire increase in surgical volume to the program. This was happening in Sierra Leone at the time, like the fact that Sierra Leone is getting richer. This is the GDP per capita in Sierra Leone at the same time as their 20s. If we truly want to develop policy methods in global surgery that push towards sustainable development, I think we need to do 3 things. I need to start looking at more than just health, looking at axes that patients might care about. And I think also need to be very careful to include the counterfactual and the confounders, so we can actually have high-quality studies that we can say, yes, this policy does or does not work. I'm preaching to the choir here. The ways that we learned about in grad school and med school, things like RCTs, case-controlled studies, cohort studies, they exist. They're expensive, they're difficult to do, but there are other ways that you can do this. Just don't buy our RCTs. There are the quasi-experimental designs through econometric analyses, and then our modeling analyses. Because my PhD happens to be in modeling, that's the way that I went for this. Happens. All right. To do one more thing before we dive into the weeds of the methods of this paper. And this question, as I've written it, is unanswerable. Witches and platforms improve all three axes of sustainable development for all surgery all around the world, everywhere. It's an unanswerable question. So I have to narrow it down. And I narrowed it down to Uganda, a country of 38 million people, 85% of whom are rural. There are 8 physicians per 100,000 people in Uganda, but most of them are not surgeons. There are 9 surgical providers per million people in Uganda. Uganda has 14,000 cancer diagnoses per year, leading to 11,000 deaths. This was my narrowing. In Uganda, for oncology, which of these different platforms improves all three axes of sustainable development? And the plan I showed you. The removal of user fees, which I UPF here, or Universal Public Finance, but basically making surgery free at the point of care. I did look at vouchers, but vouchers tend not to be in isolation. They tend to be an add-on to other policies, so I did an add-on to the other government policies. So I've got 6 government policy combinations that I'm looking at, and 3 NGO platforms. A 2-week trip that returns to Uganda every year. A mobile like that one in Ecuador that builds trucks to bring surgery out to the hinterlands of Uganda, and building a cancer hospital in southwest Uganda, where there currently are plans to build a cancer hospital in Uganda. I want to evaluate the effect of these policies on these 3 axes. I need outcomes for each axis. So for that benefit, I looked simply at the number of lives saved, number of averted, did not look at alleys, did not look at quality or anything else like that, just lives saved. Financial risk protection, the number of cases of catastrophic expense, like what somebody faced, over the status quo in Uganda. And then to equity, I looked at the distribution of these benefits across the wealth spectrum. Before I get any questions on this part. Okay.
Was defined as, or how did you define wealth?
Yes. Wealth was defined as wealth, as asset wealth from DHS. However, catastrophic expense is an income/expenditure-based measure. Catastrophic expense is any expense that's more than 10% of your total expenditures or total income. I had to find a way to transform asset wealth into some indicator. I'm not going to get into how I did that here, but yes, I just did that. The weeds here, there'll be some math. You're welcome to fall asleep, and then I'll wake you up when I get to the results. So that I chose to use is called agent-based modeling. And I'm biased, but if you haven't seen agent-based modeling before, it's really kind of a cool way to model things. It's a social model in which every individual person and 54 public hospitals in Uganda is an agent, a separate agent that responds to its own internal stochastic rules. Agents can speak, messages can be transmitted between them, multi-level networks, people within families, within villages, within regions. Most importantly, I can incorporate GIS data, geolocalization of hospitals, the road networks of Uganda. So what here is the simplest agent-based model. This is a hospital that I represented by this doctor icon here. And I placed the doctor icon at the GPS coordinates of the Gulu Regional Referral Hospital in northern Uganda. And about kilometers to the southeast, I'm placing a person. And go about her merry way until, with some probability, she gets sick. When she gets sick, she goes up the road network to the Gulu Regional Referral Hospital. Repeat this for each of the 1 million people I put in my model from the 54 public hospitals. I cycle it every day, and I run it for 15 years. I just count. I can count how deaths happen. I count how many cases of catastrophic expense happen, and this becomes my counterfactual. Because 50 years, this also incorporates all the other things that are happening in Uganda at the time that I'm pulling these policy levers. My counterfactual, I've got my confounding, and now I can start pulling these levers. What happens? Let's say if we recreate the point of care, what happens if we build trucks? So the key to this model then is what happens to the individual patient. It's a bit of a busy slide, but because I am running for 50 years, the patient has to be able to be born into the population, has to be able to die of cancer causes and non-cancer causes. They have level networks, which I realized as I was going through this talk this morning, I don't talk about these at all, but I'm happy to answer questions about these networks at the end. But the important part of the slide is actually adulthood, because I did not look at any pediatric cancers in this paper. Adulthood. This person goes about her merry way. Maybe she has kids, maybe she migrates, maybe it happened to her. She died, and at some point, with probability, she gets cancer. She has to make a crucial decision. Is she seek care, cancer? And if she is, where is she going to seek care? So this second arrow is the key to the model. She decides to seek care. She travels to that place. She may die en route. She gets to that place. She gets her treatment. The treatment may or may not kill her. If it does, it may or may not have complications, which themselves may or may not kill her, and it may or may not be successful, and then she goes home. But the arrow is really the key to the model, that choice that she makes of whether and where she seeks care. And that's based on a number of things. The preference for I to seek care at provider J is going to be based on some individual specific characteristics, male or female. How old are you? How rich are you? How educated are you? Where do you live? Provider specific characteristics, what is the quality score of the hospital? How many doctors are there in the hospital? It's going to be based on the distance between her and the hospital. And function that's near, that includes her income, Y, and the place of care, P. Term, the trivial extreme value type 1, which we're not going to talk about. But building a model like this requires a ton of data on the population. Where are, how often are they born, what's their fertility rate, what's their death rate, what's their cancer incidence, what are the quality scores of the hospitals, and to your question, can I construct an income distribution based on the asset wealth they have, the prices of care? I chose Uganda because I actually have these things.
Based on 50 years of roadmaps in Uganda and all the historical events and all those things, or just assume a constant?
So some assumed were constant. Some things I don't assume are constant. But I did assume constant. I didn't want to start 50 years ago. I wanted to start now and go forward. So the roads don't change. Yeah.
How do you put into that choice of health system? What are your inputs? I mean,
What Q or the X or all of them?
Well, I understand the cost. I understand the distance. I think my point is that people make decisions based on things that, like, we don't know, like, you know, the race-based hospital, the perceived better care, so they'd rather go there, certain type of thing, but, you know.
So like that are actually, there is one quality score, incorporate some of those things, but I think doesn't really answer your question. I think the question that you're asking is, there are things that probably aren't in here that people are making decisions based on.
I guess the larger question is, how do you know that your model mirrors reality?
Okay, hold that thought. So I developed this model. This model actually was developed and published by Ugandans about hospital choice. But then to apply that model to make sure that it actually reflects reality in something like cancer in Uganda, yes, I'm going to have to prove that to you in a bit. I will say, answering your question, but we can get a whole discussion on random utility theory. The fact is, it asks you where you want to go for your appendectomy. You talk to me about certain things, like, well, I want it to be safe, I want it to be cheap, I want it to be near, but the things that you probably wouldn't express, that I wouldn't therefore be able to put in a formula like this. And that's really the developed this, won a Nobel Prize for this, literally a Nobel Prize for putting this error term on it. But behind it is to say that this error term incorporates this sort of unobserved utility. And then there are P's on what formula for that error term should actually be. Prizes for everything. Okay. Get to what you were saying. The question? Yes. Yes, we have two mortality rates from cancer. We have an untreated mortality rate from cancer, and we have a treated mortality rate from cancer. All right, so let me, the question that what was your name? Courtney. The question is absolutely the right question. At this point, I've shown you all these things and moved characters around the screen and showed you a fancy math problem. You really should be like, so what? Why trust that your model reflects what's happening in Uganda, at least in the status quo? So I have to validate it, and validate it on a number of different levels. I'm going to start with the simplest level, which is just face validity. Am I putting people in the right place? So the model predicts stochastically, randomly, that people in Uganda are supposed to be. And this is the actual population density in Uganda. So you can call it in the south here, in the south here. Zulu, where I had that example hospital, is right here, and in Mbarara, where they're building a cancer hospital, is right there in the southwest. I'm running for 50 years, and so the population of Uganda is going to grow over the next 50 years. The UN estimates that the 2050 population of Uganda will be 114 million. So I asked my model to give 500 estimates of the 50 population, and those 5 estimates center right around 114 million. This current population pyramid in Uganda, and this population pyramid that my model predicts will be in 2050. So a little bit of fattening in the older ages as you'd expect as countries start to develop. I have 7 different cancers: prostate, cervix, breast, esophagus, capices, colorectal, and oral cavity. The overall cancer incidence in Uganda is 171 cases per 100,000 people in the population. My model predicts that the incidence of cancer in Uganda will be about 171 cases per 100,000 people in the population. So I think the next validation is the most crucial one, which is to mortality ratio. Am I really getting the people who are supposed to die from cancer truly in Uganda? Am I really getting them in my model? And the incidence mortality ratio in Uganda is 1.26. My model did 1.255. So hopefully, at least some sense, status quo is modeled well enough to represent what's happening in Uganda right now. We start pulling these policy levers and seeing what happens if I make surgery at the point of care or if I build trucks. So thank you very much. I'm going to go to results in graphical form instead of table. And I'm going to start domain by domain. So we'll start with the domain of health, they all care about. And to show you these results, I'm going to show you them the way that we in the cost effectiveness world tend to show them, which is on an efficiency frontier. Cost is on the x-axis, and benefit is on the y-axis. And because looking at the domain of health, the benefit in this figure is lives saved. So where, and this is on the north upper left, lowest, highest benefit, where E is in the lower right. And in fact, if you draw a line from the origin that connects every single policy that is closest to the northwest, you have drawn what we call the efficiency frontier. All the policies there are good. All the policies of that are dominated. You shouldn't choose the policies off that. And I'll show you that graphically in just a second. So here's a 2-week mission trip. Flying in surgeons and equipment, et cetera, every year, but you're only staying there for 2 weeks. Build is more than doing a 2-week mission trip, but gives you more health benefit. And whether you want to build a cancer hospital or a 2-week mission trip depends on if you think you're willing to pay that extra cost to get that extra benefit. But to some, because the mobile surgical unit is over here in Northwest. So it's cheaper and gives you more benefit than either of the other two. The other two are dominated by the mobile surgical unit. Draw an efficiency frontier from the origin to the mobile surgical unit. And this line will be efficient. Anything off of it, you shouldn't think about doing. The only efficiency frontier is a policy of task shifting. And again, shifting in blue and the mobile surgical unit in pink depends on whether you're willing to pay the extra bit of money to get the extra bit of health from the mobile surgical unit. Here. So everything else, if we care about health, is needed. We should choose it. If we care about health, the only things that we should choose are the surgical unit or task shifting. we care about health. We care about financial risk as well. Do the same thing with financial risk, the same x-axis, same y-axis, except the y-axis here is a catastrophic expense averted. So notice the y-axis goes negative here. Negative expense averted are cases of catastrophic expense created by policies of the status quo. Some of these policies are going to push some patients to impoverishment. So here are the policies. You can see the surgical unit is still on the efficiency frontier. The policy that is on that frontier is a policy that pays for everything. Pays costs and the non-medical costs of care. This is, if care about is financial protection, then that would give you the most financial risk protection. So that's pretty obvious. But what is in me is what happens to tax shifting. It fell off the efficiency frontier, but it fell below the zero line. Task shifting is going to create cases of financial catastrophe, which is good. Until what task shifting is doing is it's only solving the supply side part of the problem. We're creating surgical providers in places where there weren't surgical providers before. Some, as we learned at the very beginning, will choose to use those providers despite the fact that that might impoverish them. Sure.
So the cost or the risk protection for the consumer, but overall with cost shifting, having those, like the indirect costs and the indirect benefits financially, that perhaps overall contribute to better risk protection.
Can you define for me what you mean by indirect cost and indirect benefits?
So just like having these providers who healthcare perhaps have good outcomes. This person can go on, live longer, contribute to society, economic gains, the country will doing better.
A very specific definition for catastrophic expense. Definition is an outlay out of your pocket of more than 10% of your income. It doesn't take into account any of the things that you're talking about. And so this is simply an incidence measure. It's an incidence of reaching into your pocket, taking out $10,000 and paying for your C-section. What happens after that is an incredible question that as though nobody looks at. You can tell both stories. Actually, I've heard both stories. This is anecdotal now. I've heard both stories in Africa. I lost my farm. I don't know what to do now. I'm happy, but I don't know what to do now. I can now re-enter the workforce because I'm not a farmer. Therefore, I don't need my farm, and I can be more economically productive. So, a catastrophic expense is a hit that you never recover from, or that you then start to recover from, is not actually known. That's a good word, but what does it mean? How does it play up against this incidence measure of you still have to reach into your pocket and pay $10,000 to
I guess this is sort of definitional, but it almost, and you probably did it more in favor, but it's like task shifting and the mobile unit are kind of in different dimensions. Like you could, like the question of like your staffing is sort of the model and who the people are who are delivering the care, kind of one dimension. So another is like what is the infrastructure for that? So you imagine a mobile unit staff kind of level providers that have certain training. And then there's another dimension that's about how you finance it. And I'm sort of not it seems like there's artificial here about the distinction between task shifting and mobile surgical units, right? Like where you don't have an example here. It's like a mobile unit with task shifting and University of Public Finance.
Correct.
Yeah,
there were, I actually tried initially, there were something like 63 different combinations of all these things, and I didn't go through all 63.
But in a fundamental way, they're kind of conceptually. I mean, it seems like the dimensions are basically how you sit, what your training model is and your staffing model, and then there's what your infrastructure model is. And they're not.
To some degree, yes. To some degree, they are. The difference, if we want to get into the weeds, the difference between the mobile surgical unit and the task shifting model is the task model has to use the existing infrastructure. The placed in hospitals that are already there. It didn't involve building more hospitals to place them in there. Just the infrastructure as it was. The mobile surgical unit actually breaks that assumption.
So the lowest task model is basically the lowest level of decentralization you
Exactly.
get is at the district hospital.
That's it.
Kind of where it's distance to the patient.
Right.
Whereas the mobile surgical unit, you can get to within,
X number.
ends up just like like a 20 or I don't know what level depending on how many surgical units.
Right. Yeah.
Yeah.
With some hands up, there's 12 minutes left. Let me just sort of finish because we have 2 things to do, and then I'll take the rest of the questions. Okay, so the thing that I wanted to do, just to make this a little bit more clear, we've only done 2 domains, and there's a crap ton of dots on a 2 maps, and there's no way that any policymaker is going to look at this and go, clearly, I know what to do next. So to try to simplify this a little bit, we call an extended cost effectiveness analysis panel. So CEA panel, take the 2 outcomes to help the financial risk outcome, and I divide everything by its cost. So everything you see here is going to be per dollar spent, or in this case, per $100,000, just to get round numbers. All right, health benefits now are on the x-axis. The further right, the more deaths you prevent per dollar spent. Financial axis, the further to the north, the more cases of catastrophic expense you prevent, and then below that you create per dollar spent. So on this particular figure, you don't want the upper left anymore. You want to be in the upper right. Per dollar, the most health benefit and the most financial risk protection benefit. The 2 trip, uncertainly, is here. Very expensive. Cancer hospital is incredibly expensive. So it actually doesn't look that different from the 2-week mission trip because it's so expensive. So per dollar spent, you aren't actually as much health or financial risk protection benefit. The mobile unit is here. But about 2 minutes ago, I'd like to turn to, which is to say, let's make surgery free at the point of care. It's a very easy policy to implement here. Which is that if a government has the money to make free at the point of care, it should potentially move that money into building something else that kind of gets over this infrastructure problem that he's talking about. Instead of making surgery free at the point of care at the places that are already providing surgery, it should just start to get that surgery out to places that aren't providing surgery. Here are the remaining policies. Most of them cluster around the origin, but the 2, again, that stand out, and the 2 that are going to be the topic of conversation, I can tell, are the mobile surgical unit in pink and task shifting in blue. Task shifting, hands down, gives us the most health benefit per dollar spent. There is a reason that the global surgery community keeps talking about task shifting, because it gives us the most health benefit. So by creating these cases, these incidences, catastrophic expense. Now, we prevent some of those with this model, but so we don't avert nearly as many deaths. So this becomes a much more multifactorial decision making. Before we get one domain that we are interested in, which is, I'm going to show you equity in a 3rd way. I'm showing you using what we call a concentration index. So in a concentration index, I've got the wealth of the population down here, with the poorest people on the left, the people on the right. Y-axis is the proportion of benefit that accrues to that proportion of the population. So really equal policy would look like this. 20% benefit accrues to 20% of the population, 80% of the benefit, 80% of the population. A poor or a progressive policy would look like one of these 2, where benefit happens over here on the left side where the poor people live. Rich policy would look like this one, where more benefit happens closer to where the rich people live. So then all I'll do is take the end of the curve, multiply it by 2, and set up the math such that a positive number is poor, it's progressive, and a negative number is pro-rich. And here are my 9 policies and platforms. Some of them are quite pro-poor, some of them are pro-rich. Summarize them into a numerical value. What you find, the policies are most progressive are policies in general because they pay for things, and the policies that pay for things. Poor people are much more price sensitive than rich people are. So we want to increase access to the poor, we make sure that we're thinking about paying for things. So, two more slides, then we'll open up questions. My basic hypothesis was correct, that if we choose based only on health, we would be choosing task shifting. But then start to introduce things that patients might care about, like am I to be impoverished or equity? Then it becomes more difficult, more memorial, but I would say probably more patient-centered. We can conclude, first of all, that short-term mission trips shouldn't be done. This is not a novel conclusion. We've known this for a long time. Also conclude that just removing user fees is probably not an efficient way of using our health policy dollars. That we should consider things that address both the supply and demand side of the equation, like a mobile unit, which is it's equitable, but it's also really expensive. Or if you want to address just the supply side, it's something like task shifting. We need to be prepared for the unintended consequences. It's going to increase impoverishment and worsen inequity. And these consequences are unintended because we just don't look at them. It's really good in health policy. It's finding policies to take patients from here to here. But I also, to achieve sustainable development, need to look at what happens to Patricia and somebody after they leave the hospital as well. All right. Thanks all.
Going back to the task shifting side, and the cost. Task shifting leads to a lower rent cost than addition providers, or middle providers.
Yep.
So task shift, the definition you're using, means to put providers into there that didn't have certain providers to begin with, should both reduce the demand side, should both reduce the direct cost of the procedures and the indirect costs around the procedures, because we're distance less indirect cost of the patient. And so I'm wondering if you counted for those two things. You did.
Yes.
And I assume that task shifting, by this definition, is still better from a cost perspective than training more mid-level providers in centralized hospitals, or training more physician providers and turning them into decentralized.
Yeah, so I didn't look at either of those two policies, but I would assume you're right. So Alex is using phrasing that Alex might disagree on. There are direct costs and there are indirect costs. Direct costs are anything I have to reach into my pocket and pull out my checkbook for. And there's medical costs and the direct non-medical costs like transportation, because I still have to pay for transportation. In things like lost wages, things like that. Those technically indirect costs I didn't actually include in the model, but both sides of the direct costs are lower because providers are closer and because the providers don't charge as much. Yeah.
Thanks, Mark. I think when I reflected on when I read it initially, the data is extraordinarily compelling within the very specific domain of surgical oncology. That narrow your methodology. I think interesting sort of augmented, not that I'm suggesting that you or your team could do this with the data available globally, but if I'm a health policy maker, if I'm the minister that you're talking to with this data, I'm making a choice about a policy lever specifically with regards to surgical oncology. I'm probably that lever with regards to an entire division in my ministry. And task shifting for surgical oncology actually probably occupies less than a fraction of a single percent of my human resources and supply chain management within the ministry. Whereas something like outpatient care, breast cancer screening, things like that, which a lot of ministries have moved toward mobile, not surgical units, but mobile clinical units of some sort. If you have a bucket decision for example, the entirety of in country X, the division of surgery and anesthesia, or the entirety of the division of non-communicable disease or primary care, etc., are secularized. Those could have very different and potentially actually contrary results from a health cost and financial risk perspective. So I suggest here, if there's other data sets out there or other teams that are working on augmented analyses for other disease-specific areas that then could be combined with this to make more holistic policy.
I have two answers to that. The reality of funding for research projects. This was funded by a cancer, so had to include cancer, had to be. With you, we published a paper in 16 that looks at similar to this. It's a different model, but it looks at surgery broadly, and by broadly, the obstetric surgeries, trauma, and laparotomies. And honestly, many of these policies, it was just task shifting, public finance measures. And honestly, task shifting kind of behaved the same way, but the general trend was about the same.
So, let's see if I can take this question well. One of the areas that you look at is death due to cancer and death averted, but then potential introduction of complications, death and surgery and complications. And far out you extend looking at complications, and then do you get any interactions between the complications and other dimensions? So specifically what I'm thinking of as far as C-section patients in Rwanda, what we're finding is more operative infections from what we're getting. Tertiary hospitals is the #1 cause of maternal mortality right now, and 2, the #1 predictor of surgical site infections post C-section in our study is how much it costs for them to go to the health center where they would get post C-section care. So, do you those follow-up costs into account? Who's doing them? If you get a mobile clinic, who's going to see those patients post-operatively, and what are the costs for them to get that post-operative care?
So, 2 questions in there. The first published a paper out of Congo that looked at the association between anti-barriers and ex-post complications, and there was a surprising association. It's kind of weird that a barrier before is going to increase your surgical complication rate. Those sorts of things, though, are not included. Predicting who gets a complication is an increase. We know the overall rate of, say, average, and that's what we just put in there. We didn't try to condition it. And the question was on follow-up. Care. This particular model I'm presenting did not actually include that. I built a model after this that did include that, but again, it didn't change the numbers, but it didn't really change the position of the dots on the screen all that much. Yes.
So I am more interested questions out of ignorance. So what is your assumption that nothing's changing about the capacity for diagnosing the cancers, and how good are those incidence numbers? I work in TB, and the estimated incidence.
Right.
I mean, have to model something. It's to model that number,
yeah.
But it's not like number. And I guess my question, the reason for my asking about the whole diagnosis thing is because my experience, I was people wrong. So there's that people generally get diagnosed with cancer until too late. And maybe if they got surgery, it would help, but here, they would have gotten diagnosed earlier, and surgery outcome would have been very different. So, would health system intervention that has these units, would you not also then integrate that diagnostic capacity so who could be diagnosed earlier? And is any of that how is that all?
That's actually a really good question. Then we have the numbers that we have. They're from GlobalCan. Trust them, the only numbers that they had for surgical incidence and mortality. I think getting to a bit of a question I think Jean asked, there are a number of different other interventions that I could evaluate. Could have been interventions that scale up the training or the screening such that we were catching people earlier. I didn't. The model would be robust to be able to evaluate that. What is the diagnostic capacity of Uganda going to change over the next 50 years? The answer is obviously yes, it will change over the next 50 years. But how it would change, I don't know. And so I'd have to guess something completely arbitrary to do so. And as a modeler, I'm not really comfortable saying, well, I think it increased by tenfold I've got some data to hang that on. So in this model, I didn't look at any changes in diagnostic capacity. As a result, though, I'm going to be overestimating the deaths in 50 compared to the deaths now. However, I didn't do this at all. However, all models discount future events and products. So changes in the future, changes 50 years down the line, aren't going to actually make a huge difference in the overall results.